Time was for mitral regurgitation, you would wait until there were symptoms or some kind of actual objective outcome before you intervened. Now the guidelines actually suggest that for an asymptomatic patient, intervention is to be considered if, for example, it is repairable and it's severe and you have a good surgical team to take care of the patient. There is, in the February 9th issue of JACC, a paper, "The Time Has Come to Define Centers of Excellence in Mitral Valve Repair." And to talk about this, I have Dr. Robert Bonow, who is the Goldberg Distinguished Professor of Cardiology at Northwestern University's School of Medicine, Feinberg School of Medicine. First, before we go there, let's talk about this paper, which you're discussing in JACC, because it was really quite interesting.
Yeah, so I had the opportunity to comment on a paper along with David Adams that was published in JACC from the Mayo Clinic investigators, just pointing out that even in a center such as theirs, where they have high volume, really high quality surgical results for mitral valve repair, there's a small fraction of patients in whom the repair either is not complete initially or more commonly is initially repaired, and then you've got recurrent mitral regurgitation over the course of time. And those patients who have recurrent leakage in the valve have a worse outcome than the patients who have a persistently durable repair.
And by quite a bit.
Yeah, well, they follow patients for a long time. They follow patients for over a decade, up to almost 2 decades. And then, yeah, at that point in time, if there was recurrent mitral regurgitation 10 or 15 years out, there was a much higher mortality rate.
And the comment that you make in your editorial is durability matters.
Correct.
So what can we do to improve the durability?
Well, so this then gets into the issue. Some of this is technical. Some of it depends on the patient. If patients who have posterior leaflet prolapse of only the posterior leaflet, tend to have a much more likelihood of a complete and durable repair. It's when you have bileaflet prolapse or anterior leaflet prolapse, which is a trickier repair technically, where you tend to have a higher likelihood of either less complete repair or less durable repair, or both. And so some of this is the patient as well as the surgeon. But the point that Dr. Adams and I were getting into is that here you are at the Mayo Clinic, which publishes these really high quality results. And even in that setting, there's a subset of patients, which is small, who get into trouble because the repair is less than durable. So we extrapolated that to what we think may be going on in the rest of the world, including many centers that do much lower volume, where there may be a higher likelihood that a patient may have a worse outcome in terms of the repair being done in the first place, as opposed to having the valve replaced instead of repaired, because we still see this. And also the likelihood that the repair would be less than optimal. And so there are some issues regarding how we begin to define our centers of excellence.
I mean, you mentioned in the article, as you just did, the fact that you are seeing patients who are getting a valve replaced instead of repaired. What's the guideline? How can we get more patients to go through the repair process if that's better for them?
Yeah, well, it's kind of a geopolitical statement, and it's difficult. The point is that we don't have good measures. We have measures of volume, and we have measures of whether patients have a mitral valve repair, and so those data are available. And in fact, it's quite encouraging. If you have a mitral valve repair, your operative mortality in the STS database is 1% or so. And so the outcome actually can be quite good. The difficulty is that if a patient has a valve repair, we have no data regarding how well it was repaired and what the durability is. We need to begin to start defining our centers of excellence, not only in terms of what they do, but also whether they are auditing the results and reporting the results publicly, or at least even internally, so at least we're staying on top of their own information and then doing quality improvement to do a better job.
So what criteria might be good to think about?
Well, it's, again, difficult. We have not established criteria, and I think this is the whole issue. I think we are now at a point where we need to begin to define what we mean by a center of excellence. The good news is that the transcatheter therapies have kind of developed along the lines of having a heart team. That's the place to start. Let's have a heart team where you've got cardiologists and cardiac surgeons, nurses, anesthesiologists, and the cardiologists are both interventional and non-invasive who do the imaging. And let's start talking about how we can begin to identify patients for different kinds of therapies, transcatheter versus surgical. And let's also start looking at the results. And so, you can be a low-volume surgeon in a high-volume center, or a high-volume surgeon in a low-volume center. So it's not just volume alone; it's also knowing what our results are. And so I think we need to begin to work on this. I think the ACC, the SDS, American Heart Association, AATS, all these organizations that really do care about improving quality of healthcare should be looking at valve disease, because there's lots of patients with valve disease. With an aging population, we're seeing more and more patients who need intervention, whether it's transcatheter or surgical. And I think it's need to get our arms around how we begin to define quality. There's also a fair amount of heterogeneity and variability, even in simple things like how we do echocardiograms, how we identify patients. Are we identifying all the patients who need surgery? Are we sending patients too early or too late for our surgeons? Because that's also going to enter into how the patients do postoperatively, as to whether they were operated upon, too late.
Which means report your data.
Report your data. Let's talk about how we begin to define quality programs in training echocardiographers, in training surgeons, in training interventional cardiologists, and hopefully all work together so that when we have the patient in front of us, all three of those components of what we do, interventionalists, surgeons, and imagers, are providing the best care for the patient.
Finally, Kim Eagle, who is our editor-in-chief for Cardiosource, now what's acc.org.
Yes.
He recently was on a phone call. We're seeing some of the first transcatheter data for mitral valve repair, replacement.
Yes.
And he was saying that within 5 years, probably a lot of what we're doing with the valves are going to be done transcatheter. Do you agree with that? Do you think that it's that fast of a turnaround? TAVR certainly came to us fast, but mitral is a little more complicated.
Mitral is complicated. So TAVR is moving very, very rapidly. It's moving into lower threshold patients who are less risky. And I think we're going to be seeing exciting data in that front. The mitral field is much more complicated because it's a more complicated set of lesions that can cause mitral regurgitation. Not one size fits all. The device we have right now is only one device, it's MitraClip. It's evolving. We have lots of highly experienced centers, but it's the first generation device. And now we're starting to see newer devices for both repair and also for transcatheter mitral valve replacement. But those are very early on. I'm not sure 5 years for the mitral valve, but if you think into the future, undoubtedly it's going to be less invasive. So at some point in the future, this is all going to be done with smaller incisions and perhaps more and more catheters.
I mean, let's face it, it's an exciting time in this particular area.
It's very exciting. And it's evolving very, very rapidly.
Well, we have in the the February 9th issue of JACC, the paper itself from the Mayo Group, as well as Dr. Bonow's editorial comment. Please see JACC for that. And for Cardiosource World News, I'm Executive Editor Rick McGuire.